Yeah.
Then I got the chocolate lemonade.
That's what I'm talking about. Yeah, because I've done better flashcards. Can you get my flashcards?
Totally. I must say, you're the most prepared who we've had. I prepared myself. That's really good.
Yeah, that's what I'm saying. I should have got about before spring break. You want to know, like, scaling is never
I don't know, because I just went through like the tables and then it doesn't really like into relevance and like so I kind of like
That's what I'm wondering. Are you gonna post this or just your?
I think I'll just use my PowerPoint. Is there
Yeah. If you want to switch to this button right here, you have to turn the light on.
Okay. Okay. I do have
Okay.
that's kind of in the middle. Okay, perfect.
It's on that camera right now. There you go. It might take a minute. It's found under here.
Oh my gosh, it shouldn't be that hard. There's only like the chance.
If you want to try it, that's the winner, and then that's the winner.
Okay, perfect.
high school with her. Her name was Ashley. Oh, she's like Tracy's status. Did you see with them? Like, oh,
Okay, there you go. Alrighty then. Okay. Are we all back in? No.
We still have 5 minutes till pasta.
Okay. Let's get
That's totally happening. Sorry, I was
I don't get it. Especially when the two of his friends are really friends. Yeah. Who like statuses that you're not?
I can't. Oh, I can't. My daughter had an allergic reaction to her. She never had shots. Yeah.
What did it do? Did she break it down?
No, and I don't know if it's an allergic reaction or what it is. I got to go to the doctor, but it's like her whole leg is all red and it's super like firm and hard. She says it hurts really bad.
What kind of stuff did she get?
I don't know, she got like 3. She got like her NMR, just her
I've seen a few
it's like her whole leg,
I wasn't even asking. Like I was asking her a question, like trying to like, oh wait, what are we supposed to ask? Like, yeah, and answer the question.
Oh yeah.
I wasn't asking. I was just like, was so awkward. She's like, no, yes.
I did say no.
Yeah.
And then like my neighbor was really bad reaction to it, so I didn't do one.
it's hard, like it's almost like the medicine you get after your muscle, like it's almost
Have you like that?
I thought so, but I don't know. I don't know. So maybe we'll start. You guys ready? This is Maddie Miller. Yeah, Brown Miller names. She's going to do our student teaching today. You'll really enjoy her, so we'll give her your attention.
Okay, perfect. I'm excited to be with you guys today. I have been in your seat and had people come and present, and so I was like, you know, hopefully I'll do a good job so you can feel like that you're prepared for your test or whatever missing test going on for you. When I came, I was like, oh, Miss Witch taught radiology, and I'm like, you know, as long as I don't have to teach that in perio or something, then I'll be totally fine. And then today we're going to be talking about radiographs and the analysis of periodontal. So it's like, just because I thought that, that's what happened. So anyway, I graduated in 2012, so just this past May, and I'm loving it. You guys are going to be so excited when you get out there. I promise it's worth it, because I know right now it's like, you want to just, you know, wonder if it's worth it. You know, it's just, it's hard. So just wanted to tell you it is worth it, and I'm excited for you to be getting into your second year. That's exciting. So I'm going to start out today with just giving you guys a pre-test to kind of get your minds flowing. I know that's kind of no fun, but I'll only give you about 10 minutes to do it, so just do the best that you can, okay? So I'll just pass out like half of them on this side and half of them on this side, and we'll just take, like I said, 10 minutes or so and just fill out the best you can. And it's, you're not getting graded on it, you don't have to write your name on it or anything, just for my classes.
Anybody need one?
That's a little bit better, right? For white. You can turn it back on, that's fine.
You're missing one.
Did anybody not get one? Anybody got one? I got one. I made one for you anyway, just so you can have one. It does go to 10, I think, so there's just 2 on the top of there. Anyway, they're just pieces. you're done, you can just kind of like pass them to the ends or whatever, and I'll come pick them up. Still have a few more minutes if you're done. Thank you. All right, 2 more minutes. You can still keep finishing with me. I'm just going to start collecting. So you guys finished it. I think it's so cool to see how many iPads you guys have and all that. We didn't do that. I don't know if I could find even my big screen, but that's really fun though. Thanks. Awesome. Did I miss any? Right here. Oh, sorry. Thanks. All right. So I guess with that you can kind of tell what I hope you guys are going to learn from it, because I want to see what you know about before I teach it to you. And obviously you've had Perio 1 and done some exams or radiology. You've had to pass and do your evaluations on that in clinic and things. So this will kind of be a review for you guys, but I just wanted to cover everything to make sure that we know it. So it's important for everything that we do. So here's just some key learning objectives that I want you guys to be able to meet after I've taught you guys. So if you won't mind, I'm going to have you help me by just reading some of these off. So if we'll start over here, and we'll just have you guys just go, I don't know if you can see, it looks different on the screen, the dark bullet points here, but just take a turn starting over here, just read like this, the objectives. So will you start here and just read the first one?
Know the definition of the periodontum and the radiographic evidence.
Perfect.
Describe the radiographic characteristics of healthy periodontium.
Recognize and describe early radiographic evidence of periodontal disease.
Determine the importance of both clinical and radiographic examinations in the diagnosis of periodontal disease.
Perfect. Okay, I'm just going to continue here.
Identify periodontal disease, local risk factors that are visible on dental radiographs.
Describe the type of radiographs that should be used to document periodontal disease.
Identify the 3 categories of bone loss and understand their radiographic characteristics.
Describe the limitations of radiographs in the detection of periodontal disease.
Okay, perfect. So that's kind of the blah, blah, blah stuff. But if you read through some of those, I found that it really helps when you're studying to kind of know what the teacher expects you to know. So I just put it on there for your study purposes, kind of help you out there. Okay, perfect. So what is the periodontium? I know you guys know this. It's like beginning. But can someone, you don't have to raise your hand. It's not very formal, but just tell me, what is the periodontium? Right. Okay, perfect. So I wanted you, and it said to begin with the definition of periodontium. So pretty much, yep, you guys got it right on. So what can we see though in radiographs, because you can't obviously see all the periodontium in x-rays. So what can we see? Yeah, obviously the bone. And then we have three different types of bone here that we're going to cover. And then we have the PDL space and some. All right, well, you go ahead and read wherever we start off that first part there.
In order to recognize disease, a clinician must be able to identify healthy or normal radiographic periodontal appearance.
All right, and this is just a review of some radiology terms so that you guys can remember, you know, when I talk about like radiolucent, radiopaque, I know you guys probably remember that, but I just wanted to include it in here so that you, just a quick refresher. So listed here are the radiopaque structures and the radiolucent structures, and kind of, I thought this chart was actually pretty cool, because I would love to have that in my office, because my patients always look at their x-rays and are like, well, what is this here, and how many cavities do I have, is that all my fillings? And I'm like, yeah, that's okay, you know, but they, anyway, so I wanted you guys to have that. So we'll start over here. Can you just read the, what structures are radiopaque?
Yeah, enamel, dentin, compact or cortical bone, metal amalgam, and newer composite restoration.
Perfect. And then will you read the
Radiolucent structures, pulp, bone loss, PDL, space, bone defects, and bone marrow.
Perfect. And I thought bone loss was kind of interesting, so I'm like, I wouldn't have ever, I mean, you can't really see bone loss, you just see the bone that's left, right? But they included that on there, so I guess I must think that it's part of it. So perfect. We're going to just kind of go real quick into just kind of a summary of the different anatomy parts and the types of bone that you can see on here. So I know I'm just trying to keep you guys' attention, so I'm just going to have you keep helping me read if that's okay. So do we start off over here? If you'll just kind of read about cortical bone for me.
Okay, cortical bone, outer surface of the bone, and is composed of layers of bone closely packed together. Maxillary is the thin shell, mandibular is the dense.
Yeah. So pretty much what they're just saying is that the maxillary is thinner than the actual mandibular bone that you see right here. And I don't know how many of you guys have done that. Have you ever taken like a PA down here on the bottom, and you get, it's like kind of angled in the patient's mouth, and you can actually get that really like white line across the bottom that's like the cortical bone right there on the bottom. So that's what I always think of when I think of that. Okay, perfect. Next we're going to talk about lamina dura. Okay.
Lamina dura, around the roots of the teeth, appears as a dense radiopaque line.
Perfect. So can you guys see, I think this one here is probably the best picture I can see, but it just kind of comes across all the way around, and it's just like kind of the inner lining of the socket. Okay, and I thought that this was really cool because this tooth has obviously been pulled, and you can see right here the socket of where that was, and the lining. Anyway, I just thought that was interesting. I saw that on somebody's wisdom tooth the other day in my office, and I was like, oh my gosh, you can see that full tooth, it's just right in outline. So perfect, that's kind of a nice way to remember that. Okay, this one here, go ahead and read that for me if you would, Mike.
Alveolar crest, located 1.5 to 2 millimeters apical to the CEJ. The shape and density will vary from anterior to posterior regions. Anterior will appear pointed and sharp and very radiopaque. Posterior regions appear flat, smooth, and parallel to a line between adjacent teeth and their CEJs.
Okay, so can I have someone tell me in like layman's terms what that means? Because it kind of can get confusing if you don't like just break it down a little bit. So anybody have an idea how to like explain that really simply? Yeah, exactly. Well, the teeth are a little bit more closer together, so you can just see here how it's more pointed up like this, and then across there's more of a flat layer because there's more space between the teeth, right? And it shows like that, and it's a little bit flatter. And also what it's talking about is kind of how you define bone loss. So you have the CEJ. Does everyone, knows what that is, right? And that just is kind of the borderline, so you can follow it to see where the bone level is compared to where it's supposed to be. That's kind of how we look at bone loss and kind of identify it. So 1.5 to 2 millimeters is normal. So you guys know that, but just a reminder, that's kind of an important thing when you're looking at x-rays and trying to talk to your patients about their bone loss. You got to know if it's normal or not. Okay, perfect. Periodontal ligament space. I can't remember where we left off. Is with you?
Right
Perfect.
here. Yeah. Appears as a thin radiolucent line between the root of the tooth and the lamina dura. In health, the PDL space is continuous and uniform. Perfect.
So here is a good example where it's kind of continuous and uniform. And I don't like this x-ray, but I just like that you could kind of see the contrast is really good so that you can see, the light and the dark, where the space is. And I don't know if you guys can see this here, but can you see how wide that PDL space is? I had a patient the other day who I took an x-ray and I'm like, oh, she's got like an abscess infection, I thought that's what it was. And so the dentist came in and he's like, yeah, we need to remove that tooth. And it was just so mobile because the PDL space was actually just that wide. And he's like, I don't need to give her an antibiotic or anything, it's just the PDL space is that wide, there's no infection there. And I was like, you gotta be kidding. Like, it was so, there's like a halo around there too. So I wanted just to show you that because I saw it the other day and I was like, oh, I needed to remember what that was, so perfect.
Was the bite hitting really hard on that tooth?
She just actually had really bad perio, and she hadn't had her teeth cleaned for a really long time, and so anyway, we had to kind of go over that because she ended up losing multiple teeth like that. So she's like, I didn't even know it was mobile, and I'm like, well, she had a partial denture, and it was like hooking onto the back of it, and I just was like, how can you not know your partial is like mobile? But anyway, some people they don't think about their mouth, so you'll find that it's kind of interesting. Perfect. Okay, so so you can do that for me.
Dental radiographs provide an overview of the amount of bone present and indicate the pattern, distribution, and severity of bone loss that has resulted from periodontal disease.
Perfect. So I thought that this x-ray was kind of interesting. I mean, can you see how much bone loss they've had on that? I mean, that's just crazy to think that, that tooth is even still there in their mouth. But what I like to use radiographs for, and we'll kind of talk about this, is I love to use them in my patient education. And they can be a really great tool. So when you show people, your bone level was up here, and now it's getting to here, and we want to not let it get lose any more bone. And people actually really understand that. When you say bone loss, they're like, oh, okay, I'm listening. They want to hear about what they need to do different, and it's kind of an incentive for patients to feel like they need to do SRP or have that done. Because sometimes they don't want to. They were like, why can't I just have a regular cleaning? And I use this as an example to show them, you can have a regular cleaning or else you won't get you're going to continue to have bone loss unless we get all that bacteria and stuff out of there for you. So anyway, just the bone is the major reason why we have the radiographs. We need to use radiographs. Perfect. Okay, radiographic technique. This is like a quick radiology lesson all in one, talking about the right radiographic technique for exams of the periodontal disease and periodontium. So perfect. We can just start. Just read the first bullet point for me. Can you see that? Just like the black one up here, and then we'll just kind of go.
Periapical film versus bite weaning film or occlusal film. Periapical is more focused on the entire tooth, crown and root, and supporting structures.
That's kind of easy to know. You can't see, usually the whole entire root unless you do like a vertical bite wing. But you need to do a PA film for the best analysis. So perfect. Next on you read the paralleling technique.
Paralleling technique versus bisecting. Paralleling provides a more accurate record of the bone in relation to the tooth root. No need for vertical angulation and distortion.
Perfect. So I'm going to show you guys in a little bit of what can happen if you're not using, you try and use a parallel technique and you angle it too far. You can get really some distorted images, such as how much bone loss do they really have, and so on and so forth. So paralleling is really important. So next one right here about the low contrast.
Low contrast creates many visible shades of gray that make it easier to see subtle changes in bone loss.
Yeah, if you wouldn't mind. That's perfect.
Obtained by using high KVP or digital imaging.
Awesome. How many of you guys actually have used the digital imaging before? Like digital x-rays? I know we have it in the clinic, but you guys ever had a chance to manipulate x-rays with the new software and stuff? That is awesome, and I think that will be really great in helping, not only with caries, but what you can see in the bone and things like that. So I wanted to make sure that we put that on there. Okay, and this will just continue. I know this part is kind of hard, but we're going to get into the more pictures and the more visual stuff, but just continuing on about documentation of periodontal disease. So will you read that for me?
Radiographs provide direct documentation of periodontal disease, and care should be taken to provide radiographic evidence of all significant deviations from health. Proper documentation should include PAs of affected area, vertical bite wings to address the interproximal areas, while also examining root structures. Do not use horizontal bite wings or panoramic film, or any radiographs taken with bisecting angulation.
Perfect. Awesome. I'm sorry to keep saying perfect, but that was great. So with this, I think it's a little bit easier to remember what not to use, because that makes more sense to me. Panoramic film, you're not going to be able to see the bone as much as you would like, and the horizontal bite wing, it's great, but sometimes I have patients even that have so much bone loss that you can't even see the bone on their horizontal bite wing, so obviously you need to take vertical. But that and we also need to use them for insurance purposes when you get out into, working in offices. We have to submit x-rays, showing the bone loss that you've had along with your perio chart and things like that. So you need to be able to know what you need to take to provide significant evidence. Okay, awesome. We're going to start back here for me. Thanks.
The dental radiographer should be familiar with the radiographic appearance of periodontal disease. However, remember that a radiograph is a snapshot of an instant in time in the disease process.
Awesome. Perfect. Can you guys, I tried to choose some interesting pictures of bone loss, but can you guys see how much bone loss they've had on those front ones? It's like, you gotta be super careful. I had braces when I was younger, and anyway, my roots on my top teeth are really, really short, and I'm like, man, if I had even close to that amount of bone loss, I'd be missing out on my teeth. So, anyway, I just thought that was interesting to know. So, awesome. Next, if I can have you read that for me.
Yeah, so a radiograph allows the dental professional to view the amount of bone remaining rather than the amount of bone loss.
Perfect. So that's fairly self-explanatory. You guys know that. Perfect. So we're going to talk about the pattern, distribution, and severity of bone loss, okay? So there's 3 different categories, and they're pretty easy to know. So great, well, we go ahead and if you'll start, just do the horizontal now, so the next one do the vertical.
Horizontal bone loss occurs in a plane parallel to the CJs of the teeth.
Vertical, also known as angular bone loss, does not occur in a parallel plane to the CEJs and the adjacent teeth.
Awesome. So here are these examples here, and you can't really, like I said, this is a little bit different than on the computer screen. But you can kind of see here how it's horizontal. It comes across like this, and they've had this much bone loss all the way across here. Okay, but then on this one here, you can tell that the bone level is usually up here, and on this one it's clear down, obviously, in that area. So just pretty good examples I found on there of those. Okay, next.
When inflammation is the sole destructive factor, the bone loss usually appears horizontal.
And that was something new for me to learn. I found out in the book that it just talks about how you can kind of help your patients understand what type of bone loss they have. Perfect. And then this one next.
Bone loss pattern. When inflammation and trauma from occlusion are combined in causing the destruction, the bone will appear more angular.
Have you guys ever seen, like, obviously you're looking for a recession in your mouth when you're doing your perio chart, and have you seen, like, if they're a grinder or something and how they'll get, like, recession or have, some abfraction right along, like, their canines or their premolars? Have you guys ever noticed that? Well, I thought that was interesting because they talk about how it'll be like, more rare or angular in areas where the occlusion or they have some kind of trauma. So that's kind of how I remembered that, thinking of areas where they have recession. So, okay, next we have distribution.
Okay, look-wise. Bone loss occurs in isolated areas with less than 30% of the sites involved.
Generalized. Bone loss occurs evenly throughout the dental arches with more than 30% of the sites involved.
Great. You guys know that. It's kind of the same thing with localized and and generalized perios. Great.
Bone loss distribution. Important to note, vertical or angular bone loss is more commonly localized and rarely generalized.
Good. Thank you. Okay, so we have 3 classifications of severity. Let's just go over this real quick. Let me go ahead and start over here.
Slight, moderate, and severe. Bone loss is measured by the clinical attachment loss, the CAL, which is the distance in millimeters from the CEJ to the base of the sulcus of a periodontal pocket. Important to note that the clinical considerations such as gingival overgrowth or recession must be considered.
So pretty much what that's saying is you can look at the x-rays and kind of see how much bone loss have they really had, but you can't really establish a clinical attachment loss because you have to include, obviously, your clinical exam, your perio chart, and, where's their pockets at, bleeding and recession and all that good stuff. So, okay, next.
The severity of bone loss is defined as followed by the measurements of the CAL in millimeters. Slight bone loss is 1 to 2 millimeters. Moderate bone loss is 3 to 4 millimeters. Severe bone loss is 5 or greater.
Awesome. You guys know that too, and then I just thought that these were kind of some interesting pictures. And then look at that. This bone loss over here, I just think it's so interesting. I could look at bone loss all day, so it's like, oh man, how's that tooth getting staying in there? So, but anyway, you guys know that, and you're able to classify it and do, like I said, mainly using this for showing your patients visual so that you can see and your patient can see. I was doing a perio chart the other day, and I didn't look at I took the x-rays, but I didn't look at them very, as much as I should have before I did the perio chart. So I did the perio chart, and then the dentist came in to do his exam, and I looked at the bone loss in one area, and I'm like, I know that that's not a 3mm pocket there. I should have totally gone back and checked. And so I really tried to work hard in looking at my x-rays and evaluating what areas do I need to check. Is there furcation involvement? Is there, does that tooth look like there's something causing some problems? We're going to get to that in just a minute. But your radiographs can kind of be a guide when you're doing your perio chart to where you need to check, what you need to look for, and kind of help you not make mistakes or get behind on something. Great. Oh, and then these are just the ADA types that are similar, but bone loss, that's crazy down there on that one. 6mm or greater. So, okay, the benefits of radiographs. Who can read that one for me? Do we start? Perfect. Okay, thanks.
Assessment of bony changes. Fuzziness at the crest of the alveolar bone, a widening periodontal ligament space, radiolucent areas, and interceptor bone.
Okay. And just so you guys know, this is in your book, and they want you to know the 3 steps of the bony changes in your radiograph. So, kind of a hint, they wanted you to know that. I'm guessing this went tonight as well. So here's crestal irregularities, and you can kind of see, normally you have that line up here, the alveolar crest, and when it starts to get fuzzy like that, you're starting to see a little bit of beginnings of bone loss. So triangulation, that's mainly talking about in these areas where you're getting a little triangle here where it's pulling away every absorption of the bone, and you're getting a triangulation in between the PDL space and the bone walls. Good. And interceptal bone changes. So you can see here, this is what it was before, and you're trying to get these, I call them finger-like projections, that you're going to see kind of extending into the bone. So it's starting to have, that area is already having lots of bone loss, and like I said, it's like a picture of a moment in time of that activity, and you never know if something doesn't happen to it, what it's going to look like the next time you take an x-ray. So, sorry, I thought there. Okay, next, if someone would just read that top one anyway, just assessment of furcation involvement, easier to detect in mandibular roots, obviously. So here you can see pretty much straight through the mandibular roots, right? You can see whether there's furcation involvement, obviously there. You're probably going to have all the way through and probably be able to see some of it. But it's always good to look and take note of that. And what you're not going to see is furcation involvement in which area. Anybody can think of that? Like which tooth? Perfect. Yes.
Single rooted tooth.
Yeah. Yep. Something like that. Or you're going to have maybe on the maxillary. Can anyone tell me why that would be a problem? Exactly. So you're going to have 3 roots. You're going to have a palatal root, and because it's only a 2D image, you're not going to be able to see if there's furcation at all. You're going to have to double check. And anyway, just a thought for you. Okay. Next.
Contributing factors. Any other radiographic findings that may be related directly or indirectly to periodontal involvement.
And you can just read the examples for me.
Examples including calculus, overhanging restorations, dental caries, furcation involvement, root morphology, periodontal abscesses.
Great. So this is the stuff that we like to see. It's the stuff that makes x-rays interesting. When you look at your patient's stuff, you're at, that's the fun stuff at least I like to see. It's obviously not fun for your patient, but it's fun for us to look at, right? It's it makes it interesting. So here's calculus, our favorite thing, things we want to see for our board patients. Can someone will you read that for me, the top part?
Calculus is a stone-like concretion that forms on the crowns and roots of teeth due to the calcification of bacterial plaque.
You guys know that, basic. And then the next person can read just now.
Appearance, radiopaque, pointed or irregular projections extending from proximal root surfaces, less likely, but sometimes also appears as rings around the cervical portion of the tooth.
Great. So, obviously you guys have probably seen calculus on your x-rays. If not, you will, because that's kind of an indicator for your board patients. I had one, my board patient had calculus that you could see, and I was like, oh, I'm so excited, this will be so great. And then I got to boards, and he didn't even qualify. So I'm not saying it's the best indicator for that. What I'm saying is that it will show you, sometimes it can be misleading is what I'm trying to say. You need to obviously double check it. You need to make sure that it's there, but it can also be a really good hint as to where you need to double check. Sometimes patients will have a big calculus, can't think of the word right now, spicule or something on the very, very back of their number 2 or something. And if you clean it and you're like, oh, sometimes I'll look at the x-rays and be like, well, I don't know if I got that much calculus out there, and you can go back and check. So it's just, mainly it's a help for you and a tool to help your patients kind of understand. I show my patients this, and then I also will take pictures in the clinical setting, and I'll say, look at this. Can you see that this isn't supposed to be there, and why you're going to have your bone wanting to pull away from all that gunk? We need to get it off there for you. So just an idea. Next, can I have some?
Radiographs and the appearance of radiographic calculus can be especially useful in the clinical setting.
Yeah, so just kind of what we went over, but I wanted to show you that picture. It's like, no, I just want to get in there and clean it all off when you see it like that, right? Okay. Next about faulty restorations.
Faulty restorations act as potential food traps and lead to the accumulation of food debris and bacterial deposits.
So, and then someone read the just
Examples: open or loose contacts, poor contour, uneven marginal ridges, overhangs, and inadequate markings.
awesome. Okay, so we actually get to see this quite a bit. We'll see, not often do, some dentists take x-rays after they've maybe completed a filling or something and expanded functions. You'll get to see how easy it is to have an overhang or have some kind of, filling that's, either indented or overhanging like this. I always love this one. It's like, I don't know why, but it's a really common overhang picture that I've seen. And it's like, man, you can see right here where it's like already starting to build up some decay and just food debris obviously is getting caught. Here where the margin's uneven, and that one's just to show you that even margins underneath crowns and things like that can cause problems. So be aware, look at that, try and see what's, if you're seeing like obviously a localized bone loss or something there, what contributing factors can there be? And let your dentist know, because sometimes if he's done something, I had to have another day, I said, no, this is looking kind of funny, this restoration here, and he's like, you're so right, and he redid the filling because he felt like it was causing problems for our patient. So, you can, obviously you don't want to be like, obviously dentist, you just did this wrong and you're causing problems for my patient, but you just want to be able to, maybe provide some insight, and if they ask you, be able to know what areas you're talking about. Okay, and then these are just different examples. I thought this was hysterical. Look at this. Can you guys see that root there? Okay, it's like come clear across here and then down. So it's like, I don't even know how that tooth is even, I don't know. It just is crazy to me that it fit in there. Then you have obviously abscesses, furcations, and then caries can sometimes be the cause. So just some fun pictures to look at. So radiograph limitations. You guys probably already know this, and it's a little bit easy to remember, but I just wanted to go through some of these. So if I can have you guys just read one at a time, and we'll just start wherever I left off in here.
Is only a 2D image of a 3D structure.
So you guys know that obviously. Buckle, wiggly, it's kind of hard because you can't see all the directions.
Buckle bone can hide bone loss on the root.
Great. So I just said perfect.
Palatal root makes furcation detection on maxilla difficult.
Right, we went over that.
Does not provide information about non-calcified components.
Obviously, you're not going to be able to see the tissue problems. Okay.
Radiographs do not reveal presence or absence of periodontal pockets.
I'm sorry,
You're fine. Exact. Yeah, right there.
exact morphology of bone destruction.
Tooth mobility.
Great. Early furcation of bone.
Condition of bone unbuckled and
Level of epithelial attachment.
Okay, so I just wanted to actually show you guys this quick picture. It's in your book on page 346, if you guys have it. But it's just showing like the technique. Here we go.
And then turn the light bulb. And if you twist that dial, it'll zoom in. Just kind of turn it.
Oh, nice. All right, so can you guys see? Okay, so can you see the bone loss levels, how it appears on radiograph A? Like, it appears like, oh, it's okay. It's not actually as low as you might think. And then if you go to B down here, can you see actually in that bite wing how much bone loss they have? And if you didn't take, the bite wing here because of the paralleling technique or, obviously the excessive angulation, then you wouldn't know that that's how much bone loss is going on. So anyway, just talking about radiographic technique and the importance, and it sometimes can be a limitation with your radiographs if you don't take, enough, if you, sometimes it's all about patient compliance. Sometimes they just don't want to close down and they don't want to cooperate. And so you have to figure out as a clinician what you're going to do because you need to have that radiographic film. So obviously in my office we help each other with the digital x-rays. It makes it a little bit easier, so someone, you know, can hold it or have someone press a button for you or do something where you can help the patient understand you need to get that and show them that by not letting them just get out of it. Lots of times our patients will be like, oh, you know, I don't want to, this x-ray is too big for my mouth, or this isn't working, and you know, if you don't let your patients get out of it, it shows them the importance, and also, you know, helps you, so the next time when they come in, they'll just already know that that's something that they have to do and that it's important. So anyway, just an idea for you, it helps. So, perfect, I'm going to switch back now. You can help me read this. Is that, yeah, okay, sorry, thanks.
What did we mix up? Neither radiographic or clinical examinations can stand alone. Both exams provide essential information and are needed for accurate periodontal diagnosis.
So, I know those are some like, it's kind of a graphic picture there, but that's kind of what you see sometimes, you know, obviously if you're not when you're doing radiographic exam, but just the need for both. Has anyone, you know, ever tried to just do, you know, looking at your x-rays and you think, oh, this is, you know, this person's going to have great tissue, there's not any bone loss, and then they get in, and their gums are just bleeding everywhere, and you're just like, how did that happen? There's no bone loss, it doesn't, you can't, you know, obviously you have to have both, is what I'm trying to say, because bleeding is also an indication that there might be some problems. So. And then I just wanted to list this up here, so things that you look for in your clinical exam and your radiographic exam and how they go together. I like lists and being able to look at these. So if you will just real quick have one person read the clinical and then one person read the radiographic. We're almost done and we're going to play a game. So just go ahead. Yeah, perfect. You're going to read that clinical.
Evaluation of gingiva for inflammation, periodontal probing, evaluation of gingival recession, evaluation for bleeding, redness, and infection.
Great, yeah.
Examination of bone structure not visible clinically, examination of tooth morphology, examination of structures, looking for contributing factors to periodontal disease.
Great. So you guys will have that. And I told Ms. Winch if it's up to her, but I'm going to email her my PowerPoint so that you guys can have it. It pretty much follows right along with the book, but just wanted you guys to know that you can have that too as a list. So now we're going to play a game kind of about what we learned and what you guys already know. So we can, and if you guys will, turn this off. I need you guys to split into two groups. So pretty much this is just like a fun thing that we're going to do for a few minutes, and then I'll have you take the post test, and then you can be on your way. So you guys will split. I need 10 of you on this side and 10 of you on this side, and you can bring one book, and then the rest of them out, close, and put away.
I think we are 10.
Is that what it is? Oh, perfect. Okay. Well then, you might want to get a little bit closer, because I'm going to tell you what we're going to do. We are going to kind of play a game, a little bit of a race, and you're going to be able to work together as a team. Like I said, only one book or one anything, and I'm going to ask you guys some questions, and you have to switch off, and I'm going to give you guys a marker here and a marker there, and you have to decide on the answer, whether it's like draw something, whether it's write something on the board. You can decide together as a team, but it's whoever gets it on the board fast enough that I can like read and actually tell what it is, then you guys get the point. And we're going to go for probably 10-15 minutes and just kind of overview what we know, kind of a race. So better be ready to go.
Yeah.
Like I said, just one book. So you guys will have to take turns writing up here and writing. So is it like
Yeah, we should move up better so we're closer to the
Oh my gosh.
Alright, so we're just going to split it up. I don't know if you guys can see over here, but here's like where you guys can draw on this side, and then there's one on that side. So,
Do you want to source the screen up?
yeah, we can. Is anyone
I don't know if I'm offensive or
she'll tell us. And then we can discuss and help and
I'll type across the entire stage. Alright, are you guys ready? Do you know who's going to be running and writing on the board?
All right,
Yeah.
Tina.
No, I'm
Okay, because I'm going to ask the question and you guys just got to go for it, alright? So, whenever you're Soft tissue. Okay, perfect. All right, that's 3. Good job. So you guys will erase those for me. We'll get started on another one.
I think the rule should be you have to have your answer before you go to the door.
Okay. Well, that's what I called it for, but I mean, you just need to kind of decide together as a team. It's more like a team.
You don't like us calling out the answers so you guys can write them? Just kidding.
Okay. All right, next question.
You're closest.
You're one.
This one's gonna be funny. All right. Draw a picture of a faulty restoration.
Yeah, you go. Yeah, right.
Why is Josie always on?
Like a tooth and like some like restoration like up the side. I can see like that's what. Can you tell me like what part
That's
of your
2
tooth there?
teeth and there's
Overhang.
Totally. Let's cut to the tooth here and the instrument in it.
That's right. The instrument was left inside the tooth.
I'm gonna have to say that I can tell that was a little bit more of a faulty restoration. Sorry guys.
This makes me want a goldfish cracker.
I know, right? So this is your tooth and then the restoration out to the side. All right, I'm kind of like jerking off the side. All right.
It's an amalgam.
Yeah, if you guys, erase that for me and then we'll go on the next one.
I'm pretty sure we have.
Give yourself a point. You're not the point.
Oh,
Give you guys the point.
That's
You're
right.
right.
Okay.
Do your hands.
Anyone else want to go?
No one's ready. I need a back.
Okay, this one's going to be kind of a tricky one. When you're trying to adjust the contrast for radiograph that you're going to use for periodontal exam, how can you adjust it? It was
I'm pretty sure I won.
That's me! Josie loses!
First one.
Well, I give them each a point.
Oh, okay, that sounds good to me. All right.
Some besides Josie needs to run up. We've had someone different every time. Different runners.
Josie.
I wore my running shoes.
Are you going? They only have 1 point total. Sorry.
Yeah, we do.
I just want to make sure.
Okay. Let's see here. All right. Advanced typifications cannot be seen in X-rays. We went over this.
First class 1.
Dash. Perfect. So class 1. Okay, we'll take that one and then I'll ask you a better. Well, if you guys are not going to have somebody else new, then I'm going to start like taking away your points. You have to have someone new every time.
Oh, we do.
Perfect.
Yeah, I thought we could have.
Okay, all right. So what I'm talking about for this one is
Let me take my shoes off.
a tooth. Oh. Okay. Which, like, name a tooth number, you know, where you cannot see, like, if there was a furcation, like, which tooth number can you not see because of the
32.
roots?
1.
You guys got it?
No.
That's two. That's
32 is a bottom.
I know. Oh, my bad. I should be quiet. All right, good job. I'm sorry that was kind of complicated. All right, here we go. Next one.
No, you're okay. If you know it, just run off.
Yeah, I understand.
I don't know it.
We'll tell you, then we tell you.
Name two types of film that are not used when taking X-ray
Panel.
Oh, beat you just barely. I'm sorry.
It's
Does that say poor? I don't understand. I don't know what that means. It's not like radiographic.
Okay,
I'm
all
sorry.
right, let's see here.
Okay, you're up. Come.
All right, this one you guys might need to use your books for. Yeah, you can use that. There's a black one right here.
Automatic. You can put your arms on.
All right. This one is name the 3 steps of bony changes that you're going to see in x-rays.